I was with the editor-in-chief, Spencer King, earlier in the day, and I told him I had to get back here so that we could do some interviews, including for JACC Interventions. Online before print, we're looking at risk score, causes, and clinical impact of failure of transradial approach for percutaneous coronary interventions. And I want to introduce you to Dr. Olivier Bertrand, MD, PhD, interventional cardiologist at the Quebec Heart-Lung Institute. Radial versus femoral. Around the rest of the world, it's a little less of an argument, but in this country, we're still getting used to the idea. What did you find in this particular JACC Interventions paper?
Yeah, so basically we try, there is a myth that radial approach failure ranges from 5, 10%, 15%, depending on the series. So we wanted to look at our own practice when we have been doing radial approach systematically. It's the default approach since Gérald Barbeau introduced it in Quebec in '93. So we basically look at more than 1,600 procedures, and we try to categorize failure on the primary cause of failure. That, for example, you come with the lab and you don't know why the physician is shifting to femoral. And second, if there is the incidence, what is the incidence of crossover? Meaning that you try, you fail, and then you go to the femoral. And overall, we found that you have a primary failure rate of 2.7% in any clinical scenario, and 1.7% with the secondary crossover. So overall, the message is that for all patients that can present in a big academic radial center, the actual rate is less than 5% of failure. And second observation, so based on that observation, we also developed a very simple score looking at the predictors of failure, which are female gender. Female, they have more smaller radial arteries, so we just observed that it was a cause of failure. Or patient after bypass, they're also more complex patients, and cardiogenic shock. So based on these three factors, independent predictors in the multivariate analysis, we develop a very simple score from 0 to 7, and we are able to predict a failure rate from 2% to 80%, with a very high predictive value. And second observation that we also looked at is what happened with those patients that we fail. Is there an impact? And unfortunately, that's also a second observation, which is very important, that those patients, when we cannot do radial as a primary cause or as a crossover, have also worse outcome in terms of bleeding and ischemic complications. So it means that some studies, when you just compare in observational studies the two approaches, there is always a selection bias, because patients who benefit from radial have less complications. But you should, by the way, manage that those patients that you cannot do radial, whatever your experience or your local use of radial approach. I mean, those patients who fail have also much higher risk of complications, and you should pay particular attention to those patients as well.
Now, with female gender being one of the issues here, do you just dismiss them when they come in? You've got to do a femoral approach on some of these, a radial approach on others. How do you determine which is which?
Well, again, I mean, you have to understand, in my center, basically, we do radial approach as much as we can. So it was just a retrospective analysis trying to figure out. And again, I mean, we are 12 interventional cardiologists. There was also fellows, residents. So the threshold to shift might differ according to basically how you're convinced or how you tried hard. For example, primary PCI in STEMI is a different ballgame, because you need to go to reduce the door to balloon, so you may act quicker, and some physician may prefer to shift more rapidly. But overall, you have to remember that once you are past the learning curve, since we have been doing it for many, many years, I mean, basically the failure rate is less than 5%, all scenario included.
So it doesn't mean that you should not do a radial approach in a female, but just realize that could be a little higher risk, and to pay very close attention and choose your patients well.
Yes, and basically the radial approach is basically being able to stick the artery and bring the catheter in the aorta. What's done is basically the same procedures. So it's just a matter of obvious observation that female patients have teeny arteries, so it might be a little bit more complex to stick the artery. So that's perhaps one observation, and maybe some tricks like using the ultrasound guidance for puncturing the artery may help. At this time, we are exploring, but you have also to remember that female patients are also patients at much higher risk of bleeding complications. Right. So they're also patients who benefit the most from the radial approach.
So Dr. Bertrand and all, and this is in JACC Interventions, so please do go ahead and go online because it is posted now. It's a look at risk score, causes, and clinical impact of failure of transradial approach for PCI. For CardioSource World News, I'm Rick McGuire.